Good evening, esteemed colleagues and seniors. In fact, today I'll be discussing certain important perspectives on Inclisiran because this is a very new molecule that has come to the market and almost nearing a year. We have to first answer two important questions. First is what are the optimal and safe targets for LDL levels for high-risk ASCVD patients? When I mean for high-risk ASCVD patients, we Indians do follow the guidelines that is ideal for high-risk ASCVD patients. Next, most importantly, is once we reach the target, how low can we go? Because the current trend is to go as low as possible. And does this lowering of LDL cholesterol have any mortality benefits? Now, if you try to see, Indians have a higher CV risk and experience earlier CV events. What has been shown compared to the Western population, the Indian population have this thing appearance of cardiovascular disease and risk almost a decade earlier. And these elevated LDL levels, especially now we are focusing mainly on LDL levels, are extremely crucial due to the strong and linear association with ACVD. For example, around 40 milligram, 39 to 40 milligram per deciliter decrease in LDL is associated with a 21% reduction in major cardiovascular events. So it's very important to know that if we can decrease the LDL, almost 1/5 reduction in the major cardiovascular events occurs. This has been highlighted in all the trials that you see over here, that is whether they're secondary prevention trials or primary prevention trials. Let's see whether it started with the VOSCOPs, the 4S, the AFCAPs, the HPS, the lipid-4 ideal till the Jupiter. Where they tried in the Jupiter was a trial, a primary prevention trial, where they tried to go as low as possible. In fact, the achieved LDL was to the tune of approximately 5 to 10 in a tune of almost 5 years. Now, whatever guidelines you pick up, whether it's the European guidelines, the American guidelines, or the Indian guidelines, one message is very clear that lower is better. And the second message that goes is that strike early, strike strong. It is exactly like hit the iron when it is hot. If you go through the 2023 guidelines of the Cardiological Society of India or the European Society of Cardiology, it has said that in high-risk populations, the LDL reduction should be at least less than 55 milligram per deciliter. And any patient having a second CV event in 2 years, try to bring the LDL as low as 40 milligram per deciliter, which will confirm additional benefit. Let us see what the American college says. They have also echoed almost in the similar lines that was published in 2022. The clinical ASCVD at very high risk, one should go at least less than 55 or a reduction of more than 50% of what we start the therapy with. In 2023, the Lipid Association of India came up with a consensus update that possibly if we start following the Western guidelines, we're doing injustice to our Indian patients. So they brought in a category of very high severe risk, extreme severe risk category A, extreme severe risk category B, and extreme severe risk category C. And very high risk patients, you should get it to less than 50. That means they're trying to reach still further lower down than what the European or the American guidelines were proposing. When you come to extreme severe risk, in category A, the LDL reduction is also recommended to be less than 50. And one can go as low as 30 also, but this is optional. But when we go to an extreme cardiovascular risk or an extreme CV risk, you can even start decreasing beyond 30, going up to 10 to 15 milligram per deciliter. So most likely, and you all will agree that all the guidelines, the LI guidelines of 2023 are the most stringent. This has been already presented in international forums and has been accepted as one of the best guidelines for reducing the LDL cholesterol. Now, question comes in our mind that if the LDL level goes so low as less than 15, is there any problem? Is there any safety issues? This was from the 4-year trial where almost more than 25,000 patients were included. This showed that the cardiovascular benefits with further lowering of LDL has levels which has no safety concerns even with LDL below 10. Because if you see when a child is born, the LDL levels are pretty low. Even if you see the LDL levels in the monkeys or in the primates, you'll see that the LDL level is still low. So it has been seen that there is no adverse effect, there is no problem with the liver enzymes, there is no problem with the neurocognitive function, the CK elevation, the cataract-related problems, or new onset diabetes, or even non-cardiovascular deaths. This 4-year study was done over a median of 2.2 years, and this was what was seen that lower you go also, there is no issue at all. Now, inclisiran is a small Sirna. And what do I mean by Sirna? If you have asked me, what is the difference between inclisiran and a PCSK9 inhibitor? Now, the PCSK9 inhibitors are basically that they just inhibit the PCSK9, this thing that is receptors. But what happens is that the PCSK9 is actually produced in the liver. So inclisiran halts the production of the PCSK9 inhibitor. So in a way, inclisiran specifically works the liver stage and mimics the body's process of RNA interference, and it conjugates with the GalNAc for specific uptake by the hepatocytes, and as a result, the inclisiran plasma levels decline within 24 hours and are undetectable in 48 hours. So it is at the hepatic level that it starts working, and as a result, the PCSK9 inhibitor molecules are not these molecules are not produced. Now, the Indian approval has clearly been given that it can be given in adults with primary hypercholesterolemia, whether it is heterozygous familial hyperlipidemia or non-familial hyperlipidemia or a mixed dyslipidemia as an adjunct to diet. You can combine it with a statin or any other statin like drugs so that the patient can reach the LDL cholesterol levels, which they are not able to do with the pharmacological oral drugs. Next, it can be used in alone or in combination with other lipid therapies in patients with statin intolerance. In fact, what we do after a procedure and after an ACS, we put on high dose statins. When we start repeating the liver function test, we see that quite a significant number of patients do not tolerate it. And that as a result, it is not possible to continue the statins, although we have not achieved the LDL levels. So here is a this conclude that these are the patients who should be put on inclisiran so that we can achieve the targets better and we do not cause any liver dysfunction. Same is the story for bempedoic acid. When you combine bempedoic acid with statin, with HTMB, there are a lot of side effects. And in fact, these all can be tackled if you start inclisiran as first initial molecule. To be very frank, in fact, we won't be surprised to see that the indication might be extended to the fact that as soon as the patient has an ACS, don't wait to do a lipid levels also. You directly go with a shot of inclisiran because we know this will act at the liver level because your statins take some time to act, but this will act also faster. For patients with high LDL levels who are prone to many cardiovascular events and do not touch their LDL levels to the desired targets with statins, HTMB, or bempedoic acid. And moreover, as we know that whether it's PCSK9 inhibitors or it is the Sirna, that is inclisiran, it is useful in the treatment of heterozygous familial hypercholesterolemia. It's very simple. It comes in a 1.5 ml solution per syringe, and one syringe has to be given initial dose at the end of 3 months, at the end of 6 months, and at the end of 1 year. So these are basically 2 doses to be given in a year that is seen, and these are subcutaneously administered on the abdomen, especially under this thing that is inspection of a medical professional. Now the dose is 284 milligram that is to be given, and this can be given subcutaneously so the patient can be educated for the first dose and after the patient takes it. It's very interesting as here that I'd like to share from my experience, though it is officially recommended that you should give the second dose at 3 months, at 6 months, and the third dose at the other 6 months. But I have seen that with patients who are getting even the first dose, many patients have their LDL levels as less than as 15 for almost 8 to 9 months. And it has been seen that maybe some patients may require at the end of 1.5 years the second dose. But this is as per the guidelines, you have to give the doses. Now, it is if supposing a patient misses a dose in less than 6 months, he has to again come for the original schedule. And if within 3 months he misses, a new dosing schedule should be started, administered initially again at 3 months, followed by every 6 months. Now, supposing your patient has been put on PCSK9 inhibitors, then you have to maintain the LDL levels in a recommended dose so that the inclisiran is administered at least within 2 weeks after the last dose of PCSK9. That means there are many patients who may give monthly or fortnightly or 3 monthly PCSK9 inhibitors. If your patient has received a PCSK9 inhibitors, wait for 2 weeks, see the LDL levels, and then start giving Inclisiran. The Cardiology Society of India has already come up with the guidelines in 2023 for the management of dyslipidemia, and they say that first you do a non-fasting lipid profile, start with HTMB with rosuvastatin 40 or 80 atorvastatin with HTMB. If you cannot achieve the LDL to less than 50, 55, add bempedoic acid. This is at the end of 4 weeks. So you start with a 2-drug combination. End of 4 weeks, you add bempedoic acid. If you're still not able to achieve the targets, then wait for 8 weeks and then add a PCSK9 or inclisiran so that you can achieve the targets. But if you ask me what would be my strategy for it, my strategy would be start off with a high dose statins with HTMB and give one shot of inclisiran and the first go, especially for these high risk patients, because we know that these high risk patients, there is no point in waiting for 4 weeks or 8 weeks. The issue is that we have to get it as low as possible and as early as possible. So this Cardiological Society of India guidelines states that you have to do a stepwise treatment, first by a statin and STPB, then add a bempedoic acid, and then think of an inclisiran if you have not reached the targets. But in my own practice, I've seen many patients do not tolerate this algorithm. They either have hyperuricemia, they have SGPT, SGOT raised, and this is where we lack, because most of our patients, we don't do a liver function test at the end of 4 months, the end of 4 weeks. And that is where we miss. Or if you put them on bempedoic acid, many of our patients come with pain, joints, etc. We do not do a uric acid. So we have to be very careful about the side effects and accordingly start thinking of giving inclisiran. Now, if you see the heterozygous familial hyperlipidemia, definitely this is a drug that is to be given, and this has been approved along with PCSK9 inhibitors also. For secondary prevention, inclisiran in the fasting LDL is more than 2.6 millimoles per liter, despite maximum tolerated lipid lowering therapy. And what do I mean by maximum tolerated lipid lowering therapy? It depends on individual patients, whether they're tolerating statin, STB, or bempedoic acid. Now, the ACC consensus has also recommended for ASCVD and this thing that is familial hyperlipidemia. This molecule is one of the best molecules where you can give a 6-monthly dose, especially in those patients who have not developed their complications due to familial hyperlipidemia. And also in high-risk ASCVD patients, these patients have to be given inclisiran as soon as they have an acute event. Orion trials, what they call. The Orion 9 was on familial hyperlipidemia, was studied in US, Canada, Europe, and South Africa. It was given the same dose of 284 milligram versus matched with placebo. Treatment period for 18 months, and the study has been completed. Orion 10 was on ACVD for 1,500 odd patients were taken from United States, and 18-month study was done. And Orion 11 was ACVD or ACVD risk equivalent, which is done in Europe and South Africa. In fact, the same dosage followed, and all the three trials, Orion 9, 10, and 11, were based on 18 months study treatment. If you see the Orion pool analysis, you will see that most interestingly, this inclisiran demonstrates an effective and sustained LDL reduction. Please mark the words effective and sustained with lower inter-individual variability. What we mean that we can get down the LDL as early as say 3 months or 90 days, but we have to sustain it. There's no point in just again leaving the patient so that the LDL starts slowly creeping up and the patient starts having events. It has been seen that 50.5% sustained LDL reduction has been seen in these patients when you do a pooled analysis of 9, 10, and 11 Orion. And also 50.7% effective reduction LDL has also been seen. With inclisiran as a strong component given with maximally tolerated statin. Sometimes when these patients do not tolerate statins more than 20, 40 or 80 milligram, it is fair enough that you should keep a low dose of statin and then start with inclisiran to achieve the targeted levels of less than 50. And it was seen that 68% of patients achieved the LDL levels of less than 70 and 52% achieved the LDL levels less than 50. So these three trials pulled together shows that this is a very effective molecule, not only in bringing down the LDL levels, but also having an effective and sustained LDL reduction. Now, if we come to the Asian population, which was studied in the Orion 18, it was seen the geometric mean of lipoprotein A ratio to base from day 60 to 360 was significantly reduced with your inclisiran. Now, if you do the lipid levels, it is my suggestion that because we hardly have any drug to decrease the LPA levels. So decrease the LPA levels where we Asian population have high LPA levels, low HDL levels, and high LDL levels. So here possibly is a drug where you can bring the LPA levels to the lowest possible by giving them as per the dose recommended. Now, the ratio of the LPA levels to baseline levels was approximately 41% lower compared to the placebo day 330. Now, the Orion 10, it showed that inclisiran reduced levels of other atherogenic lipids and increased the HDL. Very interestingly, it can be observed we have hardly any drugs which can increase HDL. And this has been shown that inclisiran can decrease total cholesterol by 33%, ApoB by 44, non-HDL cholesterol 47, triglyceride almost a very minimal decrease of 14.9, LPA decreases by minus 21% and HDL is raised by almost plus 7.5%. Among these, total cholesterol OP non-HDL reduction had a significant p-value reduction. So it is very important that this drug does not only decrease the cholesterol or the LDL, but also decreases the LPA, the ApoB, and has a modest or a mild rise in HDL-C. And that is what you will observe when your patients are kept on this inclisiran molecule for almost years to continue. Now, inclisiran was basically well tolerated with a safety profile similar to placebo, apart from the injection site reactions. These injection site reactions are very minimal and patients are very comfortable and confident, except of course you ask me about the price, or else it is really true that the patients, they come with lipid profile reports which are possibly unimaginable. For example, if I tell you that one of my patients underwent after 2 doses of this thing that is inclisiran, I get a call from the biochemist that possibly the sample is wrong because they are not able to detect LDL in the blood sample. So don't be surprised if you see that these patients have LDL even going below zero. There are some labs which do good reports, but we have seen that LDL levels are not detected when these patients are given inclisiran. That means we have achieved the target of less than zero in these patients. The Orion 8 was an open label extension trial of the Orion 3, 9, 10, 11, which almost had more than 3,000 participants, and the long-term long-term safety of twice yearly inclisiran has been shown to be good, efficacious, when tolerated. Now, inclisiran acts in cytoplasm of the hepatocytes and not in the nucleus, so there is no risk of any carcinogenicity or immunogenicity. Common question that your patients will ask you, doctor, you're giving me a new molecule which is so costly. Is it an experimental molecule? This is a common question that is asked. Next, is this molecule have any potential for having a carcinogenicity or immunogenicity? Will I have any reactions? You have to convince your patients that we have data up to 7 years that this is a very safe molecule. Now, the results from the Orion 18, which was the largest long-term safety and efficacy follow-up trial with inclisiran, conducted till date so that inclisiran could reduce LDL levels in the long term while being well tolerated. Almost 82.7% of the patients who had atherosclerotic vascular disease were enrolled, and it was seen the results were like 78% of the patients achieved the LDL, and 19% of the patients had the global lipid target at any visit were okay, and on an average, LDL levels were reduced by approximately 50% at the end of the study, and the overall mean exposure 2.6 years with a total exposure more than 8,000 patient years. The safety has been clearly demonstrated in the Orion 8 that it was consistent as was seen in previous studies. If I start reducing the LDL, we know the outcome is good. Now, the Orion 4 and the Victorian 2P are ongoing CVOT trials with completion dates expected in 2026 and 2027. While the CVOTs are going on, a recently published pooled patient level analysis of the Orion 9, 10, and 11 provided some insight on the possible cardiovascular benefits of treatment with inclisiran. There was a 26% reduction in the major adverse cardiovascular events compared to placebo. This is a phenomenal significant reduction in the events in the long term when the patients were followed for 18 months. Now, Mendelian randomization studies with 20 billion person years of follow-up proven dose-dependent log linear association with the absolute magnitude of exposure of vasculature to LDL and the risk of ASCVD. So what do we take from this message is that start hitting hard, going as low as possible, and lastly, possibly without any side effects. And if you continue this, it will be very important to note that LDL levels, if they're reduced to the maximum level, your patient gets the maximum benefit, and also the long-term benefit is there, and the major adverse cardiac events are very minimal. It is almost like a placebo. Thank you very much for the session that you have been listening to. In fact, I hope I have given a short brief review about what is this molecule. This molecule has already struck the Indian market, and we should be very confident about using it, especially in our high-risk ASCVD patients, because what we are doing by it is we are trying to reach our targets so that we give maximum benefits to our patients.